Hello and welcome to Health and Wellbeing live in Nottingham City. Today we're going to be joined by colleagues from NUH, Nottingham University Hospitals, and we'll be talking more about the work being done on the interface between primary and secondary care. So this is part two of two-part series on this issue. Part one is linked to within the show notes, and that's where we talk to Alan Harkham and Hussein Morji, and we give an overview of the work that's been happening in Nottingham City on this issue. Today I'm joined by Mark Simmonds and Kelly, and we'll be talking in a bit more detail about how it actually works and how it functions, and some more detail about some of the things that have been achieved. So so hello Mark, hello Kelly, do you want to introduce yourselves briefly?
Yep, shall I go first? Hi, I'm Kelly Jandrell. I'm the Integration Project Lead at Nottingham University Hospitals. I support the primary secondary care interface work from an NUH perspective, but work across primary and secondary care to support the programme.
Hi, I'm Mark Simmonds. I'm an intensive care consultant here in Nottingham, and I am Deputy Medical Director at NUH.
So Mark and Kelly, I understand you've been involved with the project for a while, but it might be useful just to tell us about how you became involved and what's been your journey with the project so far. And just aware that this might be the first time that people are hearing about the interface work if they've not listened to the previous podcast. So maybe just make it clear what's happening in terms of the interface work as you tell your stories. Mark, I don't know if you want to go first.
Yeah, sure. So back in 2021, I was divisional director for medicine, and it had just been through the first year of COVID. And the medical division here at NUH covers ED, respiratory, geriatrics, you name it. It was pretty COVID centric. And we had all of the issues that COVID had left us, but also we recognized that there was a huge mountain to climb to come back out of the pandemic. And I kind of recognized that we couldn't do that alone. We can work as a hospital in isolation a little bit too much. And actually, the reality was at that point in time, the hospital was in a mess. Primary care was in difficulty. And the reality was that I think we felt that coming together and saying, well, what can I do to help you? And what can we do to help each other was a kind of bit of a no-brainer given the challenges that we had.
Good. And have you been involved from there, Mark? Have you been sort of leading the meetings, or what's been your personal involvement in the project?
So this actually grew from I think it was four of us in a room back in as things started, and as we gained momentum, actually, quite frankly, trust in each other, we started to build a range of projects that I'm sure you've heard about in the previous podcast, and we'll talk about a little bit later, that started to just build this momentum around how a primary secondary care interface project was actually not just a good thing to have for each other, but also was delivering really helpful and demonstrable improvements in patient care. So we have a meeting every Wednesday now, and that started about 18 months ago, having been a little bit more ad hoc before that. But importantly, what we've done is, from it being a really kind of friendly, informal conversation to begin with, we've managed to somehow maintain that informality in terms of how we discuss and talk things, but also have bolted on some structure and some governance, thanks to the team that Kelly leads.
That's great, and that might be a good opportunity just to bring Kelly in and ask Kelly, how have you been involved in the project, and what's been your journey with this work?
Yeah, so my journey probably started, I would say, around about the same time, but I was supporting, so I moved into the integration team about 4 years ago, and then I was supporting the team and the wider system with some system webinars across primary secondary care and Not Healthcare Trust in Sherwood Forest. At that time, these conversations that Mark's just described were taking place, and so it was felt that there was a need to have a bit of a wraparound of support and a bit of a programme structure to some of the areas that were being discussed. And I think, thinking back, they tended to fit into a number of different categories. So we've got a project plan for the work that we're doing, and we've categorised them into 5 different areas. They're culture and relationships, continuous improvements, clinical integration, digital integration, training and development, and communication. because most of the things that were being discussed kind of fit into one of those 6 brackets. So the programme plan, I was sort of involved with Simon Gascoigne and our team to create the programme plan, essentially, and build a bit of structure around the conversations. So as Mark described, they were informal discussions, but we were able to take them away and say, right, okay, where does this fit within the project plan, and can we bring anybody else from across the system in to support the discussions? And we sort of took it from there, really.
So it sounds like you've really been involved in providing some structure to those conversations, that relationship building that Mark was talking about. And I guess, I mean, Mark and Kelly, how important do you think that structure and applying that methodology is to making things happen and have an impact with this work? Is that something that's needed?
Yeah, I think definitely, because it's really easy to say that a talking shop is an interface group, but the reality is that you can put doctors in a room together from multiple different backgrounds, and you can make that either a social event, or you can make it a kind of sharing of ideas and sharing of needs. But if there's no mechanism to actually get stuff done, that sort of way of working tends to peter out over time. The reality is that by adding that layer of structure and governance to this way of working, is actually you start to gain positivity from the impact that you're having. And so the conversations that you have even more meaning, because actually out the back of it, there's action. And I think that positive feedback loop has actually led us to a position where I think we can look back over the last couple of years and say, well, actually, not only have we managed to communicate better, but we've actually got some really important things done.
Yeah, it's good. And Kelly, would you agree that that's what you bring to the project, or do you see things differently?
So I do agree, but it's interesting, isn't it? Because the way I reflect, I think, and it's so important. Yes, we do need the structure, but actually the culture that we've built has really helped me in my role. And it's not just the people in the room in terms of the clinical leads. It's me being able to. I think when you're entering into anything like this, you've just got to learn from each other. And I'm not from a clinical background, so I am learning every day about various different things. But I think it's having that kind of that being mindful that we're all in this huge health system, but we've got the patient at the heart of all we do, and actually, how can we help one another to help the patient? And I think so my job's been made easier by having like-minded people that have built this culture. But there's that I enter every conversation I have with people to do with the interface, whether they're in the interface group or not, with the journey that we've been on, because I think that's the thing that actually brings it to life and makes people want to get on board and do more. And that takes time, and it's exhausting. It's one of those things where it's fulfilling, but it's exhausting in equal measure, if that makes sense. But no, the culture and I think the relationships that we've built has really helped going forward.
Thanks.
I think that's I think that's a really interesting 2 points there. One is around how you build this sort of thing from the relationships and not the structure. And the structure helps the relationships once those relationships are in place. We've all seen in the past multiple iterations of an attempt to have a primary secondary care interface in various places around the country. But if you make it too formal, it becomes yet another meeting. Whereas actually what I think we've tried to do here is actually just get to know each other, frankly, get to know each other's worlds. And from that, great ideas and ways come forward. And the second thing that I've just completely forgotten, because give me a sec.
Don't worry, Mark. I'll ask you a question, and it might jog your memory a little bit, because I was going to just hone in on that kind of relationship element, actually, and almost rewind, because for people watching who aren't necessarily involved in primary or secondary care, maybe they're from other parts of the system, they might not fully understand the need for this sort of work. I don't know if you can spell out for us quite how bad relationships between primary and secondary care can get, because from my perspective as a GP, I have experienced some negativity towards secondary care, and I'm sure you've experienced some negativity in college toward primary care. So just speak to that need really to maybe shift a culture to a different place, if you agree with that.
So Kelly's point around focusing on the patient is the key to this, because the reality is the patient's journey doesn't start when they hit the front door of the hospital and end when they leave. And I think our secondary care clinicians, it's really easy to get really focused on that door-to-door mentality, whereas actually the reality, the patient was ill and unwell before they came to the hospital, and they will have needs after they leave the hospital. And that is where this has always been focused, i.e. how do we deal with those interfaces? How do we deal with patients before they come into an acute setting? How do we deal with it afterwards? And how can we help each other on either side of those previous fences? Now, you're absolutely right. The relationship between primary care, if you read Twitter, X, is, you could argue, is pretty terrible. You know, there's mudslinging and blame games and a kind of, it's pretty unpleasant at times. But I don't think that's the reality. I think actually the vast majority of people in primary and secondary care want the best for our patients. And the question is, do we have the mechanisms in place to allow those conversations to happen? And that's what this is about. It's really easy to forget sometimes that we all went to medical school together. We all became doctors together. We all grew up often through our training together. And then some of us became GPs and some of us became consultants. Now, you know, those are not two different tribes. They are the same tribe. And we are working together to the same goal. But the way that the system and process is set up is that sometimes it can look like that. And so what this is trying to do is to fix that interface and to understand each other's worlds better.
Yeah, absolutely. I mean, I think my experiences of, I'm almost too young just about to remember it, but it feels like there was a time where I guess the interface between primary and secondary care perhaps was better than it had gotten to. And, you know, people talk about being able to have more direct access to specific consultants on the telephone and so forth. And I think as the health system has just become more complex, you know, that's become harder to keep, really. And I think that naturally, you know, has disappeared. And this work for me has been about sort of rebuilding some of that. And I think because of the complexity of the system, we now need some structure, I think, to kind of rebuild those relationships. But I now feel I've got better access through, and we'll probably talk about NUH Fix It later on, but sort of better access into the hospital in order to, you know, have my voice heard and to solve problems and get connected with the right people. So let's move forwards. And Kelly, I was going to ask you, how, people might be listening from other parts of the system, other parts of the country, and thinking, oh, I'd like to do something similar in my area. So I was wondering if you could begin to explain the nuts and bolts of actually what actually happens and who is there and how does it function?
Okay, so I would say if you're wanting to do it in other parts of the system, I think you need to do it in not exactly the way we've done it, but start off with the conversations and build that culture. I think we've heard from other parts of the country where they might be starting to do a large project, but actually not getting very far with it because they've not got the foundations in place. But in terms of the structure, we look at it on 3 levels. So we've got strategic, transformational and operational. So we look at it from a strategic point of view that we have a twice yearly meeting with the hospital chief executive, Anthony May, and primary care, where we look at the sort of strategic direction for both. So that's a twice yearly meeting. We've then got the transformational elements, which are kind of what we build into the project plan. So some of the more sort of bigger thinking, because I think over the last couple of years we've purposely gone down the quick wins route. There are some bits of the work that we talk about that really requires whole scale sort of change across a lot large organizations, and an example of that is that we've got a written communications working group that are looking at the way that in which we communicate between primary and secondary care. We've got to engage, you know, with all of our specialties and a number of GPs, obviously. So that's huge. So they kind of go into the transformational kind of box, as it were. And then the operational sort of day-to-day is the NUH Fix It group, for example. So day-to-day things that we can do. So in terms of the operational sort of side of things and how we meet, as Mark said, every week. And that's been running now for a couple of years. And it started off, I think, with our City Place-based partnership lead, Hussein. And then we had to grow it. We quickly realised that we needed to have representatives from all across primary care. So that now includes Nottingham City Place and South Notts Place clinical leadership and their locality teams. We've got a representative from the Clinical Design Authority. We've got ICB representation. One of the deputy medical directors attends the meeting, and we've got LMC representation. So we hope that we've got everybody in the room that needs to be, but it's an open forum. We've been very clear that it isn't a closed group. And so if people want to come and shadow the meeting or join the meeting, they're very welcome to. And there was we've got a research GP who showed an interest in the primary secondary care interface group, and he is now a member of the group. So it's not a closed forum. I think that's quite important, actually. It's kind of, there's an open door, and if somebody's interested in coming to meet with the group, they're absolutely welcome to, or come and shadow. So yeah, they're weekly and have been for the last 2 years.
That's great. Kelly and Mark, we've described how we've made sure we've got the right people in the room from primary care. I'm just thinking about in terms of secondary care and about the reach to consultants and medical and other staff working in the hospital and having sort of impact and the right sort of kudos with them to make things happen. Who have we got there from secondary care?
So one of the two one of either myself or Alan Harkham or both are in the meetings, and we quite often have now a head of service or a clinician. Where we've had physios, we've had OTs, we've had SGMs, specialty general managers come to describe something that might be of interest or of use to our primary care colleagues. Now, this isn't meant to be a primary communication route into primary care. However, there are often, projects at the beginning of their of being built, and actually having a primary care view of what might help and what might work best. It's been really powerful for those people to hear. So actually, what's happening is that people are starting to say, oh, no, how do I communicate this with primary care? How do I even start the conversation? And because we've got this group, we'll say, okay, we'll just come next Wednesday, or come in 2 or 3 weeks' time once you've got the project set up, and then just throw it into the middle of the table or virtual table and say, well, what do you think? Well, how might this work? Because quite a lot of work we're doing at the moment is around demand avoidance, admission avoidance, and the process of discharge. So understanding how our therapists might interact better with primary care, for example, or what could we do around the changing reality of the personnel and professionals that are delivering primary care now. It's giving people the opportunity to just have that conversation, because it's not formalized, because we haven't gone down a route of really firm, strong terms of reference with agendas and papers and reports and accountability along the way. It's allowed that to grow organically, and I think that's an important point.
That's great. So there's a number of sort of projects and work streams that are active at the moment, and I was just wondering if there's any particular projects or things that are particularly resonated with either of you that you'd like to go into a bit more detail about to make those projects real for people out there. Either Mark or Kelly, is there anything that you want to explain in a bit more detail?
So one thing that jumps out to me is a problem that we have solved. Well, we are in the process of solving. So primary care reported through several routes that the current process for ordering and receiving the GP referred echoes and palpitations was on a standalone system, and it made the request process disjointed, and it was, I think, causing duplication for patients. Actually, this had been, I think, maybe a cause of frustration for quite some time. So we decided to have a look into whether we could build a business case to move the process over onto ICE, which is the ICE ordered communication system, which allows GPs and healthcare professionals to request diagnostic tests quickly. So primary care, we were told, we're using ICE for other diagnostic tests, but the echo and palps hadn't moved over onto there. So we began a conversation with digital colleagues and realised that actually the system that we were using was in its legacy years. And so it was beneficial to both sides to actually try and move this over. So we pulled together a business case earlier this year, and it was approved earlier this year. So the sort of transformation and the rollout of that will take place later this year. But it's an example of where we'd heard that this was causing some frustration. And I think it may, I can't assume, obviously I wasn't involved when it was maybe previously raised, but I think because of the culture we built, potentially it helped to understand both sides. And it required me to sit with a GP and get him to talk to me in layman's terms about the process, because I'm not clinical. So I said, you need to really go back to basics for me to understand and support bringing this business case and, you know, hopefully get it through to fruition, which we did. So that's an example, I think, that I would draw upon.
Yeah, I know that was really welcomed by primary care colleagues, and most people just sort of said, "Oh, finally, you know, thank goodness that's been they've been changed." So thanks very much, Kelly, for spearheading that through. Mark, is there anything in particular that you have particularly resonated with?
So I think another similar example is what we call NUH Fix It. So this again is a historic problem between primary and secondary care, which is you're a GP, you've got 8 minutes to see a patient, they need an admission, and you've got to make multiple phone calls in order to make that happen. You phone NUH switchboard and no one answers, and the frustration, you know, that this is the basal layer of the primary secondary care interface problems, I think, in the fact that actually, because both sides, primary and secondary care, don't understand what's going on the other side of the fence, the fact that, let's just make it up, the spinal fellow or the gynae SHO hasn't picked up that phone is having a direct impact on that GP, and more importantly, on their subsequent patients. Their surgery is getting behind, we're effectively wasting their time. But that gynae SHO doesn't know that, and probably isn't necessarily in their mind. So what NUH Fix It has done is it actually came from a curry, but some of the best things do, where hospital clinicians sat down with the clinical directors from primary care and said, well, what are the biggest problems? And actually this kept on coming up. It was always coming up, and frankly we knew it was going to come up, that I need to have a conversation about a potential urgent or emergency admission to the hospital. How do we make that easier and slicker? Most of the time, don't get me wrong, it works really, really well. And I think we've got some great processes at NUH, but sometimes they just don't work. For whatever reason, technical reason, the phones run out of battery or whatever, you know, really simple stuff. But from a primary care perspective, from the GP's perspective, NUH isn't doing what they said they were going to do. And you know what? I don't blame them for getting cross about that. So what we did, I took the challenge on and said, okay, well, what we need is a rapid ability for you to be able to tell us that the gynae SHO or spinal fellow isn't answering the phone. And so what we now have is a WhatsApp group, really simple intervention. We just set up with those clinical directors initially, and it's grown from there to about 30 GPs now, where if there is a problem with that urgent emergency interface communication with NUH on the day, text us and we'll try and fix it within the moment. And some of these things get fixed within minutes. So, yep, sorry, the phone's been plugged in, apologies, blah, blah, blah. But with it, what we're trying to do is to set up a mechanism that GPs feel enabled to say, look, this isn't working. Now, what's really interesting is I was like, oh, God, this is going to be a nightmare. I'm going to be getting texts every minute of the day. And the reality is it's not, because most of our systems and processes work really well, but sometimes they don't. And it's in that, I don't know, 2%, 5%. I couldn't even tell you what it is, where it's frustrating. And that's where the anecdote comes from, you know. So anecdote builds stories build resentment builds culture, blah, blah, blah. So what this is trying to do is to say, we're here. If it's not working, we'll try and fix it. And actually, we've had some really important outputs from that. Most importantly, we now know where the biggest issues are, and actually feeding back to those specialities, both in real time and also to the management structure above, to say, look, there seems to be a recurrent problem here with whatever speciality. And we've had specialities to completely review how they interact with primary care. Who's got the phone? Where does the phone sit? What happens when that person goes into theatre? So all of those, the fact that we are now thinking about the implication on the GP and the implication for the patient has really helped people think differently about how this works. So it's small. It's not. I don't think it needs to be enormous, and I don't think it needs to be even universal. But what we're getting is a taster of some of that frustration. And that's making us, and quite rightly, rethink some of our processes.
Yeah, that's a really great example of a really, really simple solution that just helps reveal where the problems are within the system, so that you can fix it and actually have real world examples. So that's such a great example. Any other examples?
Just quickly, so the reality of that is, in the past, you'd get a report every 3 months and you'd look back and go, yeah, well, okay, what am I going to do about that? In the moment, you can do something about it. And importantly, what we're also doing is logging that. And Kelly's got this now, a log of everything that's happened with NUH Fix It. So again, focuses effort on where it needs to happen.
Great. So I guess we're moving towards the end of our time together. And I was going to ask actually both of you, what do you see as coming next for the primary secondary care interface group or work? What's in the future, or what would you like to see in the future?
I feel as though we need to do some work around communication, and there's ways in which we can do that. But to really embed this, but I actually think it's about empowering people to just think. It is beyond primary secondary care in a way, but think more from a system perspective, and think about what you're doing day to day and where your communication is going to land. And if it's going to land with primary care, whether that's an admin professional or anybody through the patient journey, consultant, junior doctor, etc., just be mindful of where your communication is going. And actually, it's just about sitting back, isn't it, and going, we work in this huge system. What am I doing today that might have a bit of a positive impact on somebody else? And I do think communication is key for the programme, to be able to communicate out, because we are getting some national recognition, which is fantastic, but we do need to do some further work, I think, to embed the messages. So this podcast, is really helpful in us achieving that.
Thanks, Kelly. Mark, what do you think about the future for this work?
So I think the future of this is to grow it, and we've got a core of people, yes, mainly in leadership roles, trying to move this sort of thing forward. We have heads of service, we have people coming to the meetings, but what I'd really like to see is where there are substantial interface issues, whether that be within the emergency department or outpatients, whatever it may be, that actually we take the model that we've got and grown from that idea of relationships and trust, and build that at a more local level, local from a speciality level, and in fact grow it from a primary care perspective as well. Wouldn't it be brilliant actually for GPs who are feeling frustrated, feeling that actually their interactions with the hospital aren't quite as good as they could be, to actually be able to liaise perhaps within a specific area in order to make things better? Now, we're doing some pretty global issues and big ticket items with this particular project, but actually even and certainly at speciality level, there's just a myriad of things that we could do differently. So I would like to see the model, the sort of core of that trust and relationship building, with the structure around it, but at a more local level, both at local in terms of primary care, but also local in terms of speciality within the hospital.
Thanks, Mark. I know what I'd like to see. I'd like to see this model of working spread beyond NUH to healthcare trusts who deliver the mental health services, maybe East Midlands Ambulance Service, and other partners within the system as well. That's what I'd like to see from my perspective. So I think this has been really great work. Thank you very much, Mark. Thank you very much, Kelly, for joining us, and thank you people who've taken the time to listen to us talk about this work. One very last question, how could people get involved or learn more? So either Mark or Kelly or both of you.
They can get in touch directly with myself, and we can pop the email in the chat. So I'm at NUH, but I can support and provide information about the interface. There is information that goes on TeamNet for primary care. We push things through the place-based partnerships, and then if colleagues are in NUH at all, when we send partnership newsletters, we send things through Trust Briefing and through the medical director's office. So there's a myriad of ways, but they can reach myself, and I'm sure Mark would say the same.
Yeah. Any final words, Mark?
Keep feeding back. We need to, just keep the communications open. You know, bottling things up and you know, it all coming out in 3 month tranches with anger and vitriol on both sides of the fence. That doesn't build relationships. So how do we respond to feedback? How do we let's just keep that coming. Keep it coming both ways, and you know, that's how you build teams. That's how you build a system.
Okay, thank you very much, everybody. Thank you.